Hello everyone, my name is Amy Kaiser and today I'm going to be presenting N-acetylcysteine and vitamin D as a complementary nutrition therapy for chronic obstructive pulmonary disease. The pulmonary system involves the nose, pharynx, larynx, trachea, lungs, bronchi, bronchioles, alveolar ducts, and alveoli, and can also include support structures such as the diaphragm. The lungs' primary purpose is to facilitate the exchange of gases, as the lungs provide oxygen for cellular metabolism and consequently remove the carbon dioxide that is produced. The lungs also play a role in immune function, as mucus maintains airway moisture as well as trapping particles from inhaled air. Cilia, lining the trachea, bronchi, and bronchioles, trap bacteria and foreign substances before they enter the airway. Pulmonary disease involves COPD, asthma, lung cancer, as well as pulmonary fibrosis, and more. Warning signs of pulmonary disease include coughing and difficulty breathing, as well as excessive mucus production, wheezing, coughing up blood, or chronic chest pain. According to the Centers for Disease Control and Prevention's report on COPD trends from the year 2000 to 2014, chronic lower respiratory diseases, which includes COPD, chronic bronchitis, and emphysema, is the third leading cause of death in the United States. In looking at the death rate from 2000 to 2014, a decline was seen in both men and women, with men having a more rapid decline in death rate. Chronic obstructive pulmonary disease, or COPD, is a term that includes emphysema and chronic bronchitis. Emphysema involves destruction of the parenchymal cells of the lungs with decreased elasticity. In chronic bronchitis, the bronchi become inflamed, leading to increased mucus secretion, cough, and difficulty breathing. The largest risk factor for COPD is cigarette smoking, contributing to 85 to 90% of COPD cases. Other risk factors include occupational smoke or dust, air pollution, chemical exposure, and genetics. COPD is diagnosed through a health examination from a physician and spirometry, in which the patient blows air into a mouthpiece attached to a machine that measures the amount of air expelled in a certain amount of time. Additionally, doctors measure plasma oxygen levels through arterial blood gas tests and may also perform a chest X-ray. According to the COPD Foundation, the most common comorbidities in individuals with COPD may include asthma, kidney disease, depression, diabetes, cardiovascular diseases including myocardial infarction and stroke. Additionally, COPD patients often experience malnutrition, decreased energy intake, and weight loss. COPD is currently treated with bronchodilators, steroids, and oxygen therapy. According to the Journal of COPD, 5.9% of the U.S. population has self-reported to have physician-diagnosed COPD. According to the COPD Foundation, in 2010 there were nearly 700,000 hospitalizations, 1,468,000 emergency department visits, and 10,291,000 physician visits for COPD in U.S. adults aged 25 and older. Additionally, 16.4 million days of work were lost due to COPD in just 1 year. The age-adjusted mortality rate per 100,000 U.S. individuals was 39.7 in the year 2014 to 2015. It was found that worsened COPD outcomes occur in largely rural areas of the southern U.S., the Appalachia, and the Mississippi Delta. Finally, it was estimated that 3.2 million deaths worldwide occurred in 2015 due to COPD. Smoking is a major contributing factor in the development of COPD. Cigarette smoke narrows airway passages as well as promotes inflammation due to an inflammatory response to cigarette smoke and destroying air sacs. The development of this inflammation in non-smoking patients is not well understood. As the airway is restricted more and more as the disease progresses, gas gets trapped during exhalation, causing hyperinflation, consequently reducing inhalation capacity due to the feeling of shortness of breath and exercise limitation in the patient. Additionally, as the disease progresses, the buildup of carbon dioxide worsens, leading to a worsened ventilation-perfusion ratio in the individual. While not all patients with COPD have an oversecretion of mucus, those that do experience enlarged submucosal glands in the body because of the severe irritation to the airway due to the cigarette smoke or other irritant. Oxidative stress in the lungs amplifies COPD's effects, often leading to exacerbations, in which the patient experiences a worsening of symptoms and requires medical attention. This stress is often due to inhaled particulate matter from the air or cigarette smoke. Increased quantity of inflammatory cytokines in parts of the lungs cause structural and functional changes that worsen with disease progression. Additionally, a small percent of the population of COPD patients have alpha-1 deficiency, which is a genetic form of emphysema in which the body cannot produce the alpha-1 protein that provides protection to the lungs. Our first complementary nutrition therapy, N-acetylcysteine, an antioxidant, reduces COPD-related oxidative stress and cytokines through the scavenging of free radicals and therefore by improving oxidative stress. NAC is thought to reduce symptoms of COPD. Additionally, NAC is a mucolytic and inflammatory agent, leading many to suspect its capacity to aid in COPD management, as a main component of COPD is inflammation of the airway and often excess mucus production. Additionally, NAC is a relatively weak antioxidant, therefore high doses are required in supplementation. A single-blind, randomized controlled trial was performed by researchers in 2015 in Malaysia to determine the effect of NAC specifically on nutritional and antioxidant status in 79 male COPD patients. Malnutrition and poor appetite are often symptoms in COPD due to decreased lung capacity and therefore energy intake. Vitamin C was also studied in this trial due to its efficacy on improving antioxidant status in cigarette smokers. Participants were randomly put into 4 different groups for 6 months. One group received 600 milligrams of NAC daily, one receiving 500 milligrams of vitamin C daily, one receiving both NAC and vitamin C, and a control group. The NAC supplementation, both alone and in conjunction with vitamin C, led to a statistically significant increase in appetite and carbohydrate intake. Additionally, NAC supplementation showed a statistically significant improvement in nutritional status as measured by BMI. Therefore, NAC was effective in improving nutritional status. Unfortunately, many participants did not experience a reduction of COPD symptoms, and many had complaints of polyuria, numbness, stiffness, shortness of breath, and facial flushing. A limitation of this study was the small sample size, short study frame, and the lack of a double-blind procedure. A double-blind, placebo-controlled randomized trial was performed in 2014 by researchers in China. This study involved 1,006 individuals between the ages of 40 and 80 who were diagnosed with moderate to severe COPD and admitted to hospitals in China. Participants were randomized to an NAC group who received a 600 milligram tablet twice daily or a placebo twice daily for 1 year. Compared to the placebo group, it was found that the NAC group had a statistically significant decrease in the occurrence of severe COPD exacerbations. This shows the potential efficacy of long-term use of NAC to prevent serious COPD exacerbations in those with moderate to severe COPD. Additionally, NAC was overall well tolerated because while 29% of individuals in the NAC group experienced adverse effects, so did 26% of the placebo group. A limitation of this study was funding from the Henan Zambon Pharmaceutical Company. In 2016, a double-blind randomized controlled trial was performed by researchers in the United States on high-dose NAC's ability to improve respiratory status in COPD patients. Of the 51 COPD patients, one group received 2 900 milligram tablets twice daily, and the other group received a matching placebo. Respiratory status was measured via St. George's Respiratory Questionnaire and through lung function and circulation markers. Based on the short time the study was completed, no statistically significant difference in respiratory status was found, suggesting long-term supplementation may be needed to see effective results. While no patients experienced adverse effects, the study was terminated early due to a different study that came out during the study's duration, showing the potential for tumor growth after NAC supplementation in mouse models. This caused the researchers to terminate the study as these patients had severe cases of COPD, and the very high doses of NAC put them at greater risk for the development of lung disease. A limitation of this study includes the small sample size. While NAC does not seem to be effective in treating the symptoms of COPD, efficacy has been found in decreasing overall exacerbations of COPD, as well as improving the nutritional status of COPD patients, who are often at risk for malnutrition and weight loss. This effect was not found in a short-term 8-week study, suggesting that long-term supplementation is needed to see effects. However, safety issues and adverse effects have been found in several studies, demonstrating the need for further research on the use of N-acetylcysteine in COPD patients. For this reason, I would not recommend NAC for the treatment of COPD until further research can verify the efficacy and safety of long-term supplementation. The next nutritional supplement we are going to discuss is vitamin D. While COPD patients are often vitamin D deficient, vitamin D plays an important role in muscle functioning, which is crucial for COPD patients. It is also hypothesized that in the vitamin D deficient COPD patient, worsened muscle strength would lead to decreased pulmonary function and decreased respiratory muscle strength. Vitamin D has the potential to be a safe, user-friendly, inexpensive option for improving muscle strength in the vitamin D deficient COPD patient. Vitamin D is thought to reduce cell proliferation, increase apoptosis, and enhance cell differentiation, as well as decreasing the risk of acute respiratory infections and asthma exacerbations. Additionally, similar to N-acetylcysteine, vitamin D is thought to decrease the inflammatory response that often contributes to COPD, therefore potentially improving lung function. In this double-blind, randomized, placebo-controlled pilot trial performed by researchers in Amsterdam, 50 vitamin D deficient COPD patients were randomized to receive 1,200 IUs of vitamin D daily or a placebo. Researchers measured respiratory strength, physical performance, pulmonary functioning, as well as hand grip strength, COPD exacerbation rate, and overall quality of life. After 6 months of the study, researchers found a statistically significant increase in serum vitamin D status in those receiving the supplement, but found no statistically significant difference in any of the respiratory or pulmonary factors measured. No adverse effects of vitamin D supplementation were reported. A limitation of this study is the small sample size of 50 individuals and the relatively small dose of vitamin D. This randomized, placebo-controlled, double-blind trial was performed by researchers in Belgium in 2012. Participants included 182 patients diagnosed with moderate to severe COPD with recent exacerbations, who were randomized to receive 100,000 international units of vitamin D every 4 weeks for 1 year, or a placebo supplement. While vitamin D levels increased significantly in the group receiving the vitamin D supplement, time to first and second exacerbation, exacerbation rate, time to first hospitalization, quality of life, and death rates were not statistically significantly different between the experimental group and the control. Therefore, the vitamin D supplement did not have a statistically significant impact on exacerbations in COPD patients. However, in 30 COPD patients who were previously vitamin D deficient, they did have a significant reduction in exacerbations, suggesting the potential for vitamin D supplementation to decrease exacerbations specifically in the vitamin D deficient COPD patient. This double-blind, randomized, placebo-controlled clinical trial was performed by researchers in Iran. The participants included 63 patients who were randomized to receive 50,000 IUs of vitamin D3 weekly for 8 weeks and then monthly for 4 months, or the placebo supplement. The researchers found no statistically significant difference in lung functioning or the number of exacerbations between the experimental and control group. However, the vitamin D group had a statistically significant increase in quality of life compared to the control. Therefore, while no improvement in lung status or COPD exacerbations was found, vitamin D was found to be effective in improving quality of life in COPD patients. Additionally, no adverse effects of vitamin D supplementation were reported. Limitations of this study include the small sample size in one single medical center. Overall, no studies demonstrated the efficacy of vitamin D in the improvement of COPD symptoms or reductions in exacerbations in the general COPD population. However, variable efficacy of vitamin D has been found in the vitamin D deficient COPD populations. Also, one study found an increase in quality of life in COPD patients supplemented with vitamin D compared to a placebo. In terms of recommendations, no safety concern exists with vitamin D supplementation and no harm has been found. Therefore, I would recommend COPD patients who are specifically vitamin D deficient consider vitamin D supplementation with clearance from a physician. However, more research needs to be done to confirm and strengthen the evidence for or against efficacy. Other promising therapies that exist for COPD include probiotics, which are thought to decrease the incidence and severity of lung infections and strengthen the immune system in the COPD patient. Additionally, herbs such as ginger, cumin, peppercorns, and turmeric, which can reduce inflammation and help with coughs when added with honey or basil in warm water. Finally, a mind and body practice that has a potential to improve COPD symptoms is yoga and breathing exercises, which can potentially improve lung functioning and exercise capacity. This can decrease fatigue in COPD patients as well. Additionally, yoga can improve a COPD patient's overall well-being and quality of life through reducing anxiety and depression, which are often comorbidities of the disease. These are my references. Thank you for watching.